Hello, and welcome to this educational program titled Treatment of Acute Venous Thromboembolism, the Role of Anticoagulation Therapy. My name is Jeffrey Barnes. I'm a cardiologist and vascular medicine specialist at the University of Michigan. And this educational program is available for CE and CME through an independent educational grant provided by Bristol Myers Squibb. So let's go ahead and quickly review. As we know, venous thromboembolism, or VTE, includes both deep vein thrombosis, DVT, that's a blood clot in the legs, as well as pulmonary embolism, PE. Those are blood clots that travel up and get stuck in the arteries of the lung. Why don't we take a second and review how these clots form and travel through the body before we get into some of the treatment details? So to start, we're looking at a vein in the leg. And as you can see here, there are valves in those veins. That helps keep blood flowing in the right direction. But anytime there could be an injury or inflammation that's happening, we start to see some of those inflammatory cells attract together with the platelets, and they often get stuck behind the valves in the vein. As that happens, fibrin and thrombin starts to form together, and eventually you get a clot. That clot obstructs blood flow through the vein, and then you start to get swelling and redness that occurs in the vein of the leg. That's how a deep vein thrombosis forms, and those are why patients often have those symptoms. If we turn now to understand how a pulmonary embolism forms, that same clot that we just saw on the back of the leg, part of it could break free from the vein, say the popliteal vein, and travel on up through the inferior vena cava, through the right side of the heart, and get lodged in the pulmonary artery. It obstructs blood flow to the artery, and that's how we get a pulmonary embolism. So as we've now seen, a deep vein thrombosis in the leg and a pulmonary embolism in the lung are essentially the same general process. So our treatment approaches share a lot of similarity for both of these conditions. In fact, the way in which we treat them often differs based on the severity and can include things like anticoagulation, thrombolysis, or an other form of a percutaneous or surgical intervention. Now, anticoagulation is really foundational treatment no matter what the severity or the location of a VTE event is. So that's what we're going to focus on for the rest of this educational activity. So to emphasize this point, anticoagulation is really meant to prevent new clot from forming. This is meant to do two things. First, it prevents an existing clot from expanding or getting bigger. And secondly, it helps to prevent a new clot from forming in a different location. It also has some benefits around helping to stabilize clots, so that way they're less likely to embolize in the future. But it's really important to remember that anticoagulation does not break down a clot. So we don't give an anticoagulant as a way to dissolve a clot. That's what a thrombolytic agent does. Instead, the anticoagulant is really about preventing new clot from forming, so that way the body's natural activity for dissolving clots can proceed. Now, in all cases of venous thromboembolism, whether it's that deep vein thrombosis or a pulmonary embolism, anticoagulation really is foundational. That must be started right away. Then you can start to determine if patients are going to need additional or more advanced therapies after it. But rapid initiation of anticoagulation is one of the most important things you can do for a patient who has a DVT or a pulmonary embolism. So how do anticoagulants work? Well, to understand this in detail, we need to just briefly review the coagulation cascade. Now, I find it helpful to start in the middle, where sort of the different arms all come together. That's what we call factor 10. Factor 10 gets converted to an activated form, or factor 10A, and that's really the center of anticoagulant activity, because every molecule of factor 10A that's generated creates about 1,000 molecules of thrombin. So it's really an amplification step that happens in the coagulation cascade. So you can see why targeting factor 10 or factor 10A would be a very effective strategy for preventing thrombin and subsequent to that fibrin from forming. Those are really at the core of developing a blood clot. Let's look at a little bit more detail about how this coagulation cascade works. Okay, so let's focus now on that factor 10 we just talked about and its conversion to the activated form, factor 10A. We're going to start with the intrinsic pathway. This is the pathway which forms thrombosis, or what we might call bad clot. This tends to happen whenever there is exposure between a foreign body and the blood. Think of things like an ECMO circuit or a mechanical valve. There are also some proteins that can really facilitate the activation of this entire pathway and set off this bad clot or this thrombosis formation. So it starts with factor 12, which gets converted to factor 12A. That activated factor 12A will then activate factor 11 into 11A. And then from there, it converts factor 9 into 9A. And it's that factor 9A that helps get factor 10, the one we started talking about, over to that activated factor 10A form. So this is how the intrinsic pathway tends to flow. Now let's contrast that for a minute with the extrinsic pathway. This is the pathway that's responsible for hemostasis. Think of this as good clot. This is the process that we need whenever there's been some injury to a vessel wall, maybe a small tear or damage in a blood vessel. We certainly don't want to bleed out, so we need a good clot to form and prevent any sort of exsanguination there. So this is usually activated through tissue factor, which converts factor 7 into 7A, and that factor 7A is also able to convert factor 10 to 10A. So there's two different ways in which factor 10 can get converted to factor 10A, one through the extrinsic pathway and one through the intrinsic pathway. Now, once we've formed factor 10A, now we're into this common limb or common arm of the coagulation cascade. And here we're going to see some words that we probably are quite familiar with, like thrombin and fibrin. As we mentioned before, factor 10A is really important for converting prothrombin into thrombin. And thrombin is at the center of every blood clot, good and bad. Now, thrombin actually also converts fibrinogen over to fibrin, and that's what we'll often see in some of these thrombus or these scar tissues as they convert from thrombin into fibrin. Now, fibrin's important because we know that's also the target of those fibrinolytic agents that we've talked about before, different than the anticoagulants that we're focused on now. So we can see how we have these two different arms of the coagulation cascade. They center right at factor 10A, and factor 10A sends them down that common pathway to form thrombin and to form fibrin. So how do anticoagulants that we use here in the United States for the treatment of venous thromboembolism, how do they inhibit the coagulation cascade? Well, let's look at three of them, because these are the three most commonly used anticoagulants here in the United States. The first is warfarin, which is a vitamin K antagonist. The second is apixaban, and the third is rivaroxaban. Now, warfarin is an inhibitor of multiple coagulation proteins, and it does this by preventing their production in the liver. It's known to inhibit factor 2, also known as prothrombin, and that's in the central or the common arm of the cascade. It also inhibits factor 7, which is part of the extrinsic pathway, and then it inhibits factors 9 and 10, 9 being in the intrinsic pathway and 10 being right where those two pathways come together. So vitamin K antagonists like warfarin really inhibit all aspects of the coagulation cascade. That's very different from both apixaban and rivaroxaban. These are very specific direct inhibitors of factor 10A. That's why we call them factor 10A inhibitors or direct oral anticoagulants. They come right there where those two arms of the coagulation cascade come together and prevent the conversion of prothrombin into thrombin. Let's look at some of the differences and similarities between each of these three drugs. So we're going to compare warfarin, apixaban, and rivaroxaban. Now, the first thing we look at is which class of an anticoagulant are they? As we mentioned before, warfarin is a vitamin K antagonist. It inhibits vitamin K's activity as it develops and helps to promote the production of anticoagulant proteins. Apixaban and rivaroxaban are direct factor 10A inhibitors. Now, all of these are oral agents, but they have some other important differences. If we think about how long it takes for a drug to become therapeutic, what's that time to therapeutic onset? For warfarin, it's actually quite long. It's somewhere between 3 to 5 days for its effective time to onset. Now, contrast that with both apixaban and rivaroxaban, very rapidly available, full anticoagulant effect within about 2 hours of taking a medication. Similarly, the effective half-life of these drugs are also quite different. Warfarin has a very long half-life, estimated to be somewhere around 40 hours. That's why it takes a long time for the effects of warfarin to wear out of the system. That's very different than apixaban, which has an effective half-life somewhere around 12 hours, or rivaroxaban that has an effective half-life estimated between 5 and 9 hours. So as you can see, these factor Xa inhibitors are rapid onset and relatively rapid offset. That's in contrast to warfarin, which has a much slower time to onset and a very long time to waning out of the system. So one important thing to consider for any patient who has thrombosis or is taking an anticoagulant is the degree to which the anticoagulants are cleared by the renal system. Now, warfarin is negligibly cleared by the renal system, so we really don't have to worry about that too much. But apixaban, about 25% of that drug is cleared by the renal system. Rivaroxaban is a little higher at about 33%. So both of them, we do have to consider their renal clearance impact and therefore understand a patient's renal function whenever we're prescribing these drugs. Now, the typical dosing is also different for these different drugs. Warfarin is typically dosed once a day, but remember, the effect of that may take several days to be seen clinically. Apixaban is most commonly prescribed twice a day, whereas rivaroxaban is usually prescribed just once a day for most patients. Now, the last thing to understand about these drugs is the need for laboratory testing. For patients on warfarin, where there's a very narrow therapeutic range that we're trying to target, they need relatively frequent laboratory testing, especially an INR test. Initially, that might be twice a week, and then eventually will become about once a month. Contrast that with both apixaban and rivaroxaban, which need very infrequent laboratory monitoring, usually only once or twice a year. So let's look at the efficacy and safety data for each of these different anticoagulants, especially for the focus that we have, which is the treatment of acute venous thromboembolism. There are 3 important trials that we're going to review here. All of them compared a direct oral anticoagulant, that's one of those oral factor Xa inhibitors, apixaban and rivaroxaban, against a vitamin K antagonist, that's warfarin. So the 3 trials we're going to look at are the Einstein DVT study, the Einstein PE study, and then the Amplify study. So let's look at the first one here. The Einstein DVT and its partner, the Einstein PE study, were both open label, non-inferiority studies. And these were patients who had a DVT or PE where the predefined treatment length was either 3, 6, or 12 months. Now, these studies were both designed in the exact same way, so their primary efficacy outcome was symptomatic recurrence of venous thromboembolism, either a deep vein thrombosis or a pulmonary embolism. And the principal safety outcome was the combination of major or non-major clinically relevant bleeding. Now, the Einstein DVT study enrolled patients who had an objectively confirmed venous thromboembolism without pulmonary embolism. So these are really patients who just have a DVT. There were 3,449 patients in that study, and then they were randomized to one of 2 treatment arms. In the experimental arm, they all received rivaroxaban 15 milligrams twice a day for 21 days. At the end of that 21-day period, they then transitioned to the standard rivaroxaban 20 milligram once a day dosing. Now, Other patients were randomized to the control arm, and that was the arm where patients received enoxaparin twice a day for 5 or more days while vitamin K antagonist, usually warfarin, was taking its effect. So that's the way we usually historically have treated patients with venous thromboembolism. The goal INR for those warfarin-treated patients was 2 to 3. And then they looked for 30 days after the treatment period had continued to follow patients all the way along. So let's look at some of those outcomes. In the Einstein DVT study, here we're going to look at the efficacy outcome. So remember, this is VTE recurrence. And what you'll see here plotted in this graph on the x-axis is the number of days patients were enrolled and followed. This goes up to 1 year. And on the y-axis, we're looking at the cumulative incidence of the primary adverse event. That's the VTE recurrence. So in our standard of care arm, which is the enoxaparin with the vitamin K antagonist or the warfarin overlap, you can see that arm reaches about 3% or so over the course of the treatment period. But contrast that with the rivaroxaban arm, where it's only about 2%. And that actually had a p-value of less than 0.01 for non-inferiority, meaning rivaroxaban was at least as good as the combination of enoxaparin and vitamin K antagonist for the prevention of VTE recurrence. Now, what about that Einstein PE study? Very similar study design as we talked about. We're seeing the same kind of curve where we followed patients for 360 days. We're looking at the cumulative incidence of recurrent VTE. In this case, you can see that the standard therapy, that's that enoxaparin to vitamin K antagonist arm, had a cumulative incidence somewhere around 1.5 to 2%. And then the rivaroxaban arm had almost the same cumulative incidence. Look at how that curve completely overlaps the standard of care arm. So as we can see here, this is also a non-inferiority, very similar level of efficacy for rivaroxaban as compared to our standard therapy with vitamin K antagonist. Now, what about safety? And remember, safety was that combination of major and clinically relevant non-major bleeding. Again, we follow these patients for 360 days. We're looking at the cumulative incidence of those bleeding events. And as we can see in the enoxaparin arm first here, the enoxaparin to vitamin K antagonist arm, I should say, and then also the rivaroxaban arm, the bleeding events were almost identical. There was no statistically significant difference between these two, really showing that rivaroxaban was an equally effective and equally safe therapy as our standard of care, enoxaparin bridging over to a vitamin K antagonist. The same was true in the Einstein PE study. And again, we see that same picture here where we're looking at the 360 days, looking for the incidence of major and clinically relevant non-major bleeding. And we look to see the standard therapy arm coming up here, and then the rivaroxaban arm really showing the same level of outcome events. So again, reinforcing to us this is a safe and effective therapy. Now let's switch to that third study. This was the Amplify study. This is going to have a lot of similarities to what we saw before. This is going to be a study, however, of apixaban versus enoxaparin and vitamin K antagonist. Here, the primary efficacy outcome is also symptomatic recurrent VTE, but they added in VTE-related death as well. And their principal safety outcome was just that major bleeding. So we can't really compare the numbers directly, but we understand we're really looking at bleeding events. And for this study, they enrolled all patients with DVT or patients with pulmonary embolism who may or may not have had a DVT. There was about 5,395 of those patients who then got randomized. In this case, the experimental arm got apixaban 10 milligrams twice a day for 7 days, and then switched over to their standard of apixaban 5 milligrams twice a day. Now, the standard of care arm, like we saw before, was enoxaparin twice a day for about 5 or more days until the vitamin K antagonist, that's warfarin, reached an INR goal of 2 to 3. And in this case, they followed up at 6 months in that study. Now, on the left side of the screen here, we're going to look at the efficacy outcome. This is going to be looking at VTE recurrence or VTE-related death. And again, these patients were followed for almost 1 year. That's what we see on the x-axis. And our cumulative incidence of this efficacy outcome is on the y-axis. So first, as we see that conventional therapy arm, that's the group that got enoxaparin bridged over to a vitamin K antagonist, you can see that come up to be almost 2.5%. Now, the apixaban arm group was slightly numerically lower, and you can see that graph now coming up to about 2% total by the end of the study period. If you flip over to the right side of the screen, we see our safety outcome here. This again was major bleeding, and this is where things got a little more exciting. As we follow these patients for almost a year, we see that in the conventional therapy, the enoxaparin to vitamin K antagonist arm, we have just shy of 2% of patients developing a major bleed. But the apixaban treated patients, they had a much lower rate of bleeding, shy of 1%. And that actually had a statistically significant reduction in the rate of major bleeding. So how do we think about this all together? Well, there's really two different strategies for treating patients with acute venous thromboembolism. On the one hand, we have our traditional strategy where there's a parenteral lead-in. We start with some form of a heparin agent, and then we switch over to an oral. And traditionally, that was done with enoxaparin or maybe unfractionated heparin, leading into warfarin, our vitamin K antagonist. Now, there have been two other direct oral anticoagulants that have been studied. They also required that parenteral lead-in, and then you switch to either dabigatran, 150 milligrams twice a day, or edoxaban, 60 milligrams once a day. But those are pretty rarely used in the US because they require parenteral lead-in. So the real difference is in the oral-only strategies. And this is where we have the option for using either rivaroxaban or apixaban without any parenteral lead-in. So in the first stage, we have our initial management. That's the first 5 to 21 days. If you're going to use warfarin as your treatment, you are going to use a form of enoxaparin or another form of heparin during that time. But in our oral-only strategy, we're going to use a pretty high total daily dose of either rivaroxaban, 15 milligrams twice a day for 21 days, or apixaban, 10 milligrams twice a day for 7 days. We then transition over into our primary treatment phase. This can last anywhere from 3 to 6 months. And in this case, patients in the standard arm, the historical arm, usually got warfarin or a vitamin K antagonist. But nowadays, most patients are using that oral-only strategy. So this is where we use rivaroxaban, 20 milligrams just once a day, or we use apixaban, 5 milligrams twice a day. Now, after patients complete their primary treatment, again, that's going to be about 3 to 6 months, many, but not all patients will continue into a secondary prevention phase. And that really goes beyond those initial 3 to 6 months. And in this case, we actually have the option to continue our current dosing, or in the case of rivaroxaban and apixaban, we can even cut those doses in half. So let's look at some of the data that helps us understand why we can do that. The first was called the Einstein Extension Study. This is a study in patients who had been treated with rivaroxaban, who had completed a course of treatment, really asking, what dose should we use? And the primary efficacy outcome here was the same thing we saw before, symptomatic recurrent VTE. The safety outcome was a major bleeding outcome. So in this study, they enrolled patients from the Einstein DVT study who had completed 6 to 12 months and who had equipoise as to whether or not they should continue. Now, in this case, they enrolled almost 1,200 patients and randomized them to rivaroxaban 20 milligrams once a day or to placebo for an additional 6 to 12 months. And what we find is that when you continue rivaroxaban, that's going to be in this graph on the left side, we have a significant reduction in the rate of recurrent VTE compared to placebo. That's going to be a little bit on the right in blue. So we actually have a statistically significant reduction from about 7% to just shy of 1.5%. Now, the flip side of that is that there is more bleeding. So we see with rivaroxaban, you have an increase in bleeding. About 6% of those patients had either major or clinically relevant non-major bleeding. That's in comparison to the placebo arm, which only had a rate of 1.2%. And the biggest difference really was driven by the clinically relevant non-major bleeding group, where we see a difference of 5.4% in the rivaroxaban arm compared to 1.2% in the placebo arm. Now, there was also a study called the Amplify Extension Study, and this was a study where we looked at patients who had completed a course of anticoagulation, and there was equipoise about whether or not we should continue them as well. In this study, the primary endpoint was VTE recurrence or death, and the major safety outcome that we looked at was major bleeding. So these patients, there were about just shy of 2,500 of them who had equipoise about whether we should continue therapy or not were randomized. And the randomization had 3 different arms. The first arm was actually a lower dose of apixaban, 2.5 milligrams twice a day. The second arm was our standard apixaban therapy, 5 milligrams twice a day. And then the third arm was the placebo arm. And we followed all those patients for 12 months. And what you can see in this slide here is that the reduction in recurrent VTE or death, that was the efficacy arm, was fairly similar between both of the apixaban groups. So our first group was apixaban 2.5. Our second group here is apixaban 5. Both of those had much lower rates of recurrence than the placebo arm. And when we switch over to the safety outcome, that's the major bleeding outcome, we can see that major bleeding was really similar amongst all 3 groups at 0.5% or less. Clinically relevant non-major bleeding was a little bit numerically higher in that half dose apixaban group, 2.5, and even more so in the standard apixaban group compared to placebo. And so when you combine both of those together, you do see that there's relatively similar bleeding outcomes between the apixaban 2.5 and placebo groups, but it's a little bit higher with the apixaban 5 group. Now, one of the biggest questions people ask is, what kinds of bleeds are people having? And so if you look at all of the patients who were in the VTE studies, we have some good meta-analysis data to help answer those questions. So what you're going to see here is a plot, a forest plot from a meta-analysis looking at a couple key types of bleeding outcomes. Now, across the x-axis of this is going to be the risk ratio. What is the risk of a specific type of bleeding when you compare the direct oral anticoagulants, those are things like apixaban and rivaroxaban, with the standard of care vitamin K? So if you're to the left of this number 1, what's called the line of unity, that really says the risk is lower with the direct oral anticoagulants. But if you're on the right side, it tells you that the risk is a little higher. So what we see for the first outcome, and probably our most feared outcome of intracranial bleeding, the relative risk, the risk ratio is reduced in patients who received a direct oral anticoagulant. In fact, the risk ratio is 0.37, meaning that there was a 63% reduction in the risk of intracranial bleeding for patients treated with a DOAC compared to a vitamin K antagonist. Similarly, we see a risk reduction for fatal bleeding of about the same mark, risk ratio of 0.36. Now, for major GI bleeding, we see that the point estimate is a little bit to the left of the line of unity, but that confidence interval crosses 1. So we would say there's probably no difference here. And that for clinically relevant non-major bleeding, it is actually shifted in favor of a DOAC, a risk ratio of 0.73, so about a 26% reduction there as well. So overall, our randomized trials would tell us that using a DOAC is not just more convenient, but it's actually safer than a vitamin K antagonist. Now that's great, and randomized trial data is super helpful, but what about some real-world data? Does that match up with what we've seen? Well, here's some large data looking at the rates of VTE recurrence and clinically relevant bleeding between the different types of drugs that we just saw in the clinical trials. So for the first one here, we're looking at apixaban, both DVT and PE patients. And what you can see in this graph on the left is that the warfarin group had a higher rate of VTE recurrence than the apixaban group. And over on the right side, we see for clinically relevant bleeding, those two curves overlap, suggesting the rate of bleeding was the same. In this next one, we looked at rivaroxaban-treated patients who had a deep vein thrombosis. And in this case, we actually see that the rate of recurrent VTE was higher in the warfarin group than it is for patients who received rivaroxaban. And on the right, again, we can see that the bleeding largely overlapped, although towards the tail end of this particular cohort study, we can see that the bleeding does get a bit higher with the vitamin K antagonist group. And then in the last one, we have our rivaroxaban-treated patients who had a pulmonary embolism. Same pattern. For VTE recurrence, the warfarin-treated arm is higher than the rivaroxaban arm. And on the right, we see that those bleeding events seem to be exactly the same between warfarin and rivaroxaban. So some good data to remind us that the real-world data seems to largely match what we saw in the randomized trial. Now, what if we look sort of overall, so at a much larger set of real-world evidence. Here we can see evidence of effectiveness in the top. So is this preventing VTE recurrence? And looking at the types of patients in all the different direct oral anticoagulant trials. And when we look at the effect estimates, the real-world ones are in the open circles, and the randomized trial ones are in the closed circles. And by and large, we see that they are very similar. Sometimes we actually even have some better outcomes in the real world efficacy. So for instance, in the RECOVER-2, in the Hokusai VTE, and in both the Einstein DVT and PE studies, those open circle ones, the real world evidence, actually have effect estimates that are more in favor of direct oral anticoagulant therapy than vitamin K antagonist therapy. And when we look at some of the safety data, what we can see here is that no matter which study you look at and their comparator groups in the real world, none of them were showing clear harm with a direct oral anticoagulant. Most of those circles, both open for real world and closed for randomized trials, are similar. Some differences here, but nothing sits all the way to the right side of that line of unity. So none of them really calling out harm. So as we stop here and we think about what are our main take-home points as we are treating our patients with acute VTE, remember, anticoagulation is the foundation of all acute VTE treatment. And that's because anticoagulants prevent VTE recurrence and extension. Now, our direct oral anticoagulants, or DOACs, they are direct because they block a single spot on the coagulation cascade, usually that factor 10A, which is so important. And it's also important to remember that these DOACs have some clear advantages over vitamin K antagonists, such as a much shorter onset and a much shorter half-life. But they also have more renal clearance, something we have to consider. Now, on the whole, from both our randomized trial data and our real-world evidence, we know that DOACs are at least as good as, maybe even better, and likely safer than the vitamin K antagonists when we're using them to treat patients with acute VTE. And we know that after 3 to 6 months of therapy, we can use a half-dose DOAC as a way to prevent VTE in the long term. So hopefully this has been a great summary for you as you think about how to treat your patients with acute DVT and PE.